Hi all, my name is Dhanapasani. Currently, I am working in a St. James's Hospital Coronary Care Unit as a nurse manager. In this presentation, I am going to talk about process mapping and improvement on a telemetry allocation process. Before going into telemetry monitoring, let us find out what is telemetry. Telemetry is remote cardiac monitoring to detect a life-threatening arrhythmias through a small box called telemetry box, which is attached to the patient's bare chest through a sticky dots called electrodes. So what this small box does? So it will detect the abnormal rhythms coming from the heart, and it will send those rhythms in a form of signal to the main telemetry hub, where the telemetry nurse is monitoring these abnormal rhythms. So what happens? So if some of the rhythms, heart rhythms, like atrial fibrillation, ventricular fibrillation, ventricular tachycardia, so these rhythms are fatal. So these rhythms, if not treated, they might cause a cardiac arrest and patient might die within few hours. So these rhythms needs proper identification as well as a monitoring. So that's why telemetry monitoring or remote cardiac monitoring is very important in hospital. So nowadays there is an increased need of telemetry monitoring and less supply of telemetry boxes. That is making uh, difficulty for a patient needing for the box. So in America, it is estimated that telemetry monitoring increases the daily cost of a patient care by $53 to $82 compared to non-telemetry days. In brief about telemetry hub in St. James's Hospital Coronary Care Unit. So we have 24 telemetry boxes available in our coronary care unit telemetry hub. So this telemetry hub is led by the cardiology consultant, and this team consists of registrars, junior doctors, lot of telemetry nurses, IT professionals. So this hub provides around the clock cardiac monitoring with a dedicated nurses working 12 hours shifts both day and night. And currently a significant of number of patients from the emergency department and various hospital wards are waiting for telemetry monitoring. So let's see the current telemetry allocation value stream. So the telemetry monitoring requests come from various department of the hospital, that is from emergency department, cath lab and wards. So uh, to the hospital, the patient will be coming through the GP referral. So as you can see there, the first step in the process is the doctor will assess a patient and order a telemetry in a EPR, that is electronic patient record, and same time he'll inform telemetry nurse that this patient needs the telemetry box. And the second step, the telemetry nurse will go through all the boxes, and she will also go through the requests, and she will prioritize whom to give a box first, depending on the American Heart Association guidelines. And the next step is the telemetry nurse has no authority to discharge a current telemetry patients currently who are monitored on a telemetry. The telemetry nurse doesn't have any authority to discharge them, so she has to wait for a doctor, that is a cardiology doctor, to come and review the boxes. And after reviewing the box, the doctor can pre-up a box, and that pre-up box can be given the patient who is waiting for the telemetry, that is in ED or a cath lab or in a wards. So once the box is available, the telemetry nurse will discontinue the telemetry monitoring of the current patient, uh, from the EPR. Then the same time she will ask the ward staff to discontinue and disconnect the box and get the box to the telemetry hub, so that she can use this box for the waiting patient. So once the box will come to the hub, again the telemetry nurse will call the ward nurses and say that the box is available. You can collect the box and connect this box to the patient waiting for a telemetry. And once the nurse will collect the box from the telemetry hub. She will connect it to the patient who is waiting in ED, cath lab or wards. Then the ward nurse will call up the telemetry nurse saying that I connected the box to this particular patient. After all this, the telemetry nurse starts monitoring this patient, and she will document uh, the monitoring in a EPR as well as in a paper. So here you can see the total lead time is 478 minutes, and cycle time is 79.5 minutes. So why there is so much delay in telemetry monitoring? So why the patient has to wait for 78 minutes? So some of the reasons are the availability of telemetry boxes. As I said, in currently we have 24 boxes only, and there is a lot of demand. And second thing is review and deallocation process. So the nurse has no authority to discontinue a telemetry box. The cardiologist doctor has to come and review the boxes, then he has to pre-up a box. So there is no consistency in reviewing by the doctors by telemetries. So that's why there is a lot of delay in lead time. And the third thing is communication and coordination issues, as because once the box is discontinued, the telemetry hub nurse has to call the ward nurse and inform that this box can be discontinued from the current patient, and you can get the box down to us as soon as possible. To inform this, the telemetry nurse has to call several times because ward nurses are very busy, and they will ignore the calls, not purposefully, because they are very busy in other tasks and all. That's why the telemetry nurse has to make a lot of phone calls to inform that discontinue this box, and bring the box to the telemetry hub. And the same way, when the box is available, the telemetry nurse has to call back to the ward, get the box and connect the box to the patient. For this also, telemetry nurse has to make so many phone calls. So there is a lot of time waste here as well. Apart from that, once the telemetry box is available in the unit, um, because the ward nurses are very busy, they might send the box immediately after 10 minutes, or it might take after 1 hour as well. So because of this, there is a lot of waste of time that increases the lead time as well as the cycle time. And final allocation of the box to the patient as well. Collecting the box time takes a time because of the transportation issues and all, that increases the lead time as well as the cycle time. Recommendations of countermeasures. So first recommendation is integration of ECG strips into electronic patient record. So if the ECG strips are integrated into electronic patient records, then the doctors can review the telemetry data remotely. So they don't have to go to telemetry hub physically. So that saves their travel time as well, and that time can be used in their other tasks. And this decreases the lead time and decreases the cycle time. Second countermeasure is introduce and other scheduled telemetry review time. So physicians should have consistent time to review the telemetry data. That is, they should review the telemetries every day two times, early in the morning 9 o'clock and 5 o'clock in the evening, to free up the box. Third one is nurse-led telemetry discontinuation. So at the moment, nurses have no authority to discharge current telemetry monitored patients. So they have to wait for doctors. So according to the American Heart Association, um, it can be done because telemetry monitoring is not for lifetime for any patient, because telemetry monitoring has a time schedule. For example, if the patient admits with a chest pain, he needs only 24 hours of telemetry monitoring. If there is no arrhythmias, patient is stable in the 24 hours, he doesn't need a further monitoring of telemetries. So uh, with this, the nurses can able to decide if the patient has no arrhythmias, patient is stable, they can able to make a decision and they can able to discontinue a telemetry monitoring without consulting a doctor. So that gives a more empower to nurses to discharge a patient for telemetry. The next one is using a electronic patient record for messaging or using a mobile phones or a bleeps for communicating with the ward staff. That will decrease the lead time as well as a cycle time. Fifth recommendation is allocating a telemetry response nurse. So allocating a telemetry response nurse, all telemetry related queries can make a communication smoother and easier. So each ward should have a communicating response nurse and she should handle all the queries related to telemetry from the telemetry hub. Sixth recommendation is using a pneumatic tube system or an internal courier or a telemetry porter for telemetry transportation. Seventh recommendation is creating a real-time telemetry dashboard. A live dashboard showing a telemetry unit availability, pending requests and allocation queue to improve transparency and prioritization and gives the telemetry nurses clearer visibility of demand, reducing manual coordination effort as well as ensures high priority patients are addressed first. So eighth one is the request capital investment in additional telemetry units. If all these measures will fail, then the hospital has to look to increase the telemetries from 24 to 36 or 48. So that might need a lot of money as well as budget. Proposed methods of evaluating the effectiveness of countermeasures. First one is key performance indicators, KPI monitoring, and second one is comparing data pre and post implementation of above countermeasures. Staff feedback and satisfaction surveys that is conducted regularly and focus group sessions with the physicians, telemetry nurses and ward staff to capture their experiences with the new processes. Carry out routine audits to assess on compliance with scheduled telemetry reviews, adherence to American Health Association guided monitoring durations, proper use of nurse-led discontinuation protocols, documentation in EPR, track frequency of dashboard access, time of last telemetry review entries, and messaging response times to know the effectiveness of dashboard and system usage. Patient safety and outcome monitored by metrics on number of missed or delayed detection of arrhythmias or any adverse incidents. Regular review meetings conduct a structured monthly multidisciplinary review meetings with the stakeholders to analyze progress, review data, and refine interventions. Proposed methods for sustaining countermeasures. First one is develop a standardized protocol. Develop clear hospital-wide standard operating procedures (SOPs) for telemetry initiation, review, and discontinuation. Also include decision-making criteria based on American Heart Association guidelines. These protocols should be easily accessible within the electronic patient record system and in a physical reference materials across the wards. Second one is education and training. Provide a regular training sessions for a new and existing staff in telemetry hub and in a ward on telemetry protocols. Nurse-led discontinuation, EPR use and dashboard tools. Include these education sessions in nurse and physician induction program to ensure consistent practice across the hospital. Third one is appoint unit-based champions. Designate telemetry champions on each ward, could be the telemetry response nurse, to act as the point of contact for questions, support, and compliance monitoring. These champions can also serve as local trainers and process advocates. Fourth one is regular telemetry reviews. Ensure scheduled telemetry reviews are part of the daily ward rounds and adherence to timings integrate automatic EPR reminders or calendar prompts or for physicians to perform a review designated times. Fifth one is use real-time monitoring and dashboards. Maintain and update the live telemetry dashboard to continuously display unit availability, pending requests, and turnout, turnaround times. Sixth one is monitor compliance and provide feedback. Regularly audit adherence to telemetry review schedules, nurse-led discontinuation practices, and proper documentation. Share feedback with departments to recognize good practices and address areas needing improvement. Seventh one is conduct monthly reviews on performance. Establish monthly meetings to review telemetry process metrics and staff feedback involving a multidisciplinary team. Depending on feedback, adjust protocols as necessary. Assign responsibility for telemetry oversight to a designated community read or a lead physician to ensure accountability and regular review. Use of terminology is the last one. Technology can be utilized to reduce manual tasks. Example, automatic expiration of telemetry orders after guideline-based timeframes. To maintain and improve telemetry workflow, work with IT department. So this is the future value stream telemetry mapping. So you can see here after implementation of recommended steps, you can see some of the steps are eliminated and you can see the lead time is 71 minutes and cycle time is 40.5 minutes. And here we are using the nurse-led telemetry discontinuation so that the process takes faster and it reduces the lead time and uh, and reduces the cycle time as well. So you can see here the difference, the metric that is the total lead time. Current state is 478 minutes, projected future state is 71 minutes, and you can see the improvement that is 85.15 percentage of improvement, and total process time is 79 minutes, that is cycle time, and projected future state cycle time is 40.5 minutes. So you can see the improvement 49.6%. So you can see here activity ratio is increased as well, and the improvement is 30%. So what are the take home points? The proposed process improvements for telemetry allocation are projected to significantly increase efficiency, reduce delays, and optimize resource utilization within hospital. By implementing targeted countermeasures, including ECG integration into EPR, scheduled telemetry reviews, nurse-led discontinuation, improved communication methods, and real-time dashboards, the total lead time is expected to decrease by approximately 80.5 to dropping from 478 minutes to 71 minutes. Additionally, process time is projected to decrease 49.1% and activity ratio is anticipated to increase from 16.6% to 57%, clearly indicating a leaner, more value driven process. These improvements not only streamline the telemetry workflow but also improve staff workload, reduce patient wait times for telemetry monitoring, and help in safer, more timely clinical decision making. Sustaining these changes through standardization, training, and regular review will be essential to maintain the gains and support ongoing quality improvement across the hospital. Thank you for listening.